Hi everyone, my name is Claudia De Santis and I am the managing editor of the Cochrane review group Multiple Sclerosis and Rare Diseases of the CNS. I'm working with the unit of epidemiology statistics at the Institute of Neurological Science of Bologna in Italy, and I will share the event today. So welcome everyone. And I'm seeing a lot of people from all around the world. So we would love if you could share in the chat where are you from, and I don't know if it's morning, afternoon, and evening, and whatever you like to share with us and other participants. You are also welcome to share your contacts and interact with each other so we can make this event a real global conversation. I will start with some housekeeping. So please note that we are recording this webinar and that your microphone is muted for the moment. So it's muted since the speakers are talking, but you can always open your camera and share your questions in the chat or in the Q&A box, and we will address them at the end of the presentation. And at that point, we will also give you access to the microphone again. So today we are going to talk about reproductive health for women with multiple sclerosis, and we are going to touch several angles. And it is my pleasure to present to you the first two speakers that will bring us a clinical perspective. So the first one is Dr. Riley Bove. Riley is a practicing neurologist and clinician scientist in the University of California, San Francisco Weill Institute for Neuroscience. She's an international leader in research and on clinical management of women with MS. Her research is supported by the National Institute of Health, Department of Defense, National MS Society, Foundation, and industry sources. Riley sees patients in the UCSF Multiple Sclerosis and Neuroinflammation Center, where she provides comprehensive care for individuals with MS that is informed by their sex, gender, reproductive goals, and more broadly by their life phase and goals. And the second speaker will be Dr. Shanthi Viswanathan. Shanthi is a consultant neurologist and head of department. She is the lead for clinical neuroimmunology at the Tunku Abdul Rahman Neuroscience Institute at Kuala Lumpur Hospital in Malaysia. So I'm really happy to give you the floor, and you are welcome to share your slide and your presentation. Thank you.
Thanks so much. Hi there. So happy to be here with you all and to see people from really all over the world logging in on this chat. I am just going to share my screen quickly. It's just taking a moment. Apologies. There, does this look correct to you all?
Yes, maybe
Perfect.
You can put in presentation mode.
Yep, perfect. Okay, all right. So sorry, it's all just a bit laggy. Please let me know if this doesn't work, but just to hop right in. So I'm excited to talk to you a little bit about the overview of how far we've come in terms of understanding reproductive health for women with MS, focusing on what has been learned in the United States, Canada, Europe, mostly, and then handing it over to my partner here, Dr. Viswanathan, to talk about expanding the conversation into other settings. So we really have come a long, long way since our first studies, understanding the link between sort of women's health and MS. And when we think about the lifespan of a woman, there are really a lot of reproductive transitions and considerations around women's health that we shouldn't stop being surprised about happening and actually really plan for successful management of women with MS during these different reproductive and life transitions. And we've seen certainly since You know that 1998, when a landmark New England Journal article was published by Confavre, which showed that during pregnancy there's this immunotolerant state, and then postpartum there's a rebound risk. Since that sort of landmark paper, we've seen really an expansion in research on MS and pregnancy. And we've also seen an expansion of guidelines. And just to point to a few sort of consensus guidelines that have been written, this one is recent in neurology clinical practice, and it really helps the clinician kind of think through from if the woman if the patient is of childbearing age, really how do you go through counseling and how do you think about this at every visit to just really be mindful of whether this is someone who might get pregnant in the future, if they don't want a pregnancy, how to prevent it, if they do want a pregnancy, how to best plan for it to optimize the health of the patient. I also want to point to the importance of vaccines. Before we start MS disease-modifying therapies, we have to really think if this is a woman of childbearing potential, whether she's really up to date on vaccinations that may be very relevant during her pregnancy. So this is just a recent table on that theme. What we've also learned is that proactive management of pregnancies is better than reactive management. So historically, people put women, sort of followed women through their pregnancies, took them off their medications, did MRI surveillance. If there was a new spot, they then reacted, and that was reactive after injury had happened. And so you can see these relapses, these women in one of our research studies, they had a lot of relapses before pregnancy, the little triangles during and postpartum. And what we've seen is we've been shifting patients to B-cell depleting therapies like rituximab, which is one of the WHO essential medicines, is that we really abrogate the relapses during and postpartum. Really, we've also seen a focus on the maternal-infant dyad. So it's not just the mother, it's not just the infant, really what is best for both, and understanding that disease management for the mother actually helps prevent complications, prevent depression, stabilize things for the mother and the baby. So how do we think about DMT discontinuation currently, knowing that we have so many products on the market? There's certainly one approach is to follow the labels, but they're inconsistent within a single drug between the FDA, the EMA, and other regulatory agencies. Even within a class, they're inconsistent as well. So the labels are reactive as well, and the same principles are not universally applied because the labels come out at different times. And because of that, following the label is not actually very evidence-based. You could also wait 5 maximal half-lives based on exponential decay, but we know that some medications like fingolimod and natalizumab get a rebound risk. We know that teriflunomide needs sort of accelerated washout, and if we're waiting 5 maximal half-lives, we're putting the patient at risk of their MS flaring up. So another is really to weigh the known risks and benefits to patient and really understand the real-world data. Certainly, if there's unintended pregnancy, when possible, referring to a high-risk OB and getting a fetal ultrasound should be considered. So where we've seen is that we have this expansion of potential itinerary options or menu options for patients. I've flagged the medications that are the WHO essential medicine list medications, so rituximab, cladribine, and glatiramer. And these medications, these self-injectables, are probably okay to continue at least through the first trimester. These medications are induction therapies where you complete the entire drug cycle, and then women can go 2-3 years off therapy entirely and have a nice long window to conceive. The B-cell depleting therapies are really nice to continue up to 3 months, 0 to 3 months before pregnancy, and then start postpartum, and natalizumab is even being used during pregnancy as well because stopping it can be so deleterious. We also have some medications where there's this rebound potential, and we think about a bridge therapy to prevent, to switch the patients from a medication to B-cell depleting therapy off. So just to drill down a little bit on the concept of the B-cell depleting therapies, again, because this is one of our WHO essential medicines, rituximab, and also because we get really good benefits here, is we know that placental transfer for immunoglobulins starts at week 20. And so if we actually just time infusions to 0 to 3 months before conception, by the time you have your 5 half-lives, the drug is out of the system at the by the time it could cross the placenta, there's basically no drug on board. And so what we've seen when we've used this approach is that there's no drug in cord blood, minimal, no drug in the babies have normal B cells, and also we have really excellent sustained maternal disease control. So whereas we say that about 20 to 30 women, percent of women relapse postpartum, and about 50% have new brain injury postpartum on MRI, when we treat women with B-cell depleting therapy throughout this course, we have very, very low risk of relapses. Fertility treatments are used increasingly globally, and really just when we use the modern data, there are varied types of fertility treatments, and we do not see an increased risk of relapses as long as the mother is managed very well, or the woman is managed very well in terms of her medications. And just to remember that if there isn't going to be an embryo transfer, so if there's fertility preservation and such, medications don't need to be stopped, because it's only when there's a potential embryo, potential fetus, that we have to think about this. So I mentioned that about 50% of women have new lesions on MRI postpartum. This is one of the most sort of sensitive, vulnerable times across the lifespan for someone with MS. And so what do we know about risk? We know that the inherent disease severity affects the risk of postpartum relapses. We also know that breastfeeding and early initiation of therapies are protective. So how do we put these two together, breastfeeding and early initiation of DMTs? We use this concept of relative infant dose, this sort of the proportion that the baby would get relative to the mother. Typically at an RID of 10% is considered acceptable, and actually a lot of the medications are way under 10%, way under 1%. And for the IgG1 monoclonal antibodies like rituximab or ocrelizumab and such, we've really seen this increasingly. We also see it with these other medications in this category. These are low RID, but they could be orally bioavailable, and so the considerations may be different. These are data that I presented yesterday here at the CMSC, the Sopranino study that followed maternal and ocrelizumab infusion, followed the drug into the mother's bloodstream, full dose, into the mother's breast milk, RIG less than 1%, and then any breast milk, if the drug is in breast milk, it's going to be basically pooped out by the baby, and when you measure drug in the baby, you don't see it. So the mother can get full dose, and the baby sees none of it with lactation. A few other points here. The 4th trimester is a critical period in the MS course. Women have elevated risk of morbidity, hospital readmission, elevated risk of depression, and such. And so it's very important to not abandon patients during their 1st trimester postpartum or 4th trimester, but really focus on mental well-being, social, societal well-being, bowel, bladder, and physical well-being. If we want to prevent pregnancy, really any contraception can be used for most women. Long-acting reversible contraceptives are very effective if someone does not plan a pregnancy. If we're thinking about female-specific compartments, so gynecological health, we are seeing some increasing concern around risk of vaginal infections, inflammatory vaginitis, and HPV-mediated cervical cancer in women who are on immunomodulatory therapies. So what do? We need to absolutely think about HPV vaccination, as well as screening, pap smears, HPV tests, etc. Finally, moving to the perimenopause and postmenopause, what's the difference? The perimenopause are the last years before a woman's final menstrual period and the first years after. The postmenopause is all the rest of the woman's lifespan. 40–50% of the lifespan is in the postmenopause. And women with MS get menopause right at age 51 and a half, certainly in the United States and Europe and Canada. And this is actually very culturally variable, this age, but we don't see an effect of MS on this age. So during the perimenopause, we want to focus on management of vasomotor symptoms, a stepwise approach to overlap symptoms like these, which can really be common to both the menopausal transition, perimenopause, and to MS, and then comprehensive clinical management. In the postmenopause, we want to think about the common concerns that arise: genitourinary syndrome, bone density loss, joint pain. Think about prevention of neurodegeneration, and then just wellness, cancer screening, wellness activities, and management of comorbidities. So I'll stop here and hand this over to Dr. Viswanathan and take any questions as they arise.
Thanks, Riley. So I'll shift now towards the clinical side. Can you all hear me? I'm just going to share my slides.
Yes, we can hear you.
So I'll let you control the slides. I'd like to thank the Cochrane Group and the MSIF for this opportunity to share conversations between myself and Malaysian women with MS on reproduction, our shared global concerns, existing regional knowledge, and the need for more research, education, and data. Next slide, please. So current studies on Asian women with MS and reproduction is limited, as we can see from this PubMed search, but this space is really evolving as its importance increases. In Malaysia, preconception counseling is increasingly being incorporated into clinic discussions, though it may not have been in the past due to a lack of awareness or prioritization. Usually, these conversations are initiated by the women themselves wanting more information. So here, physician education is needed while balancing regional cultural sensitivities and taboos with regard to reproductive counseling. More data too is urgently needed, as we can see from this global map on my right on the availability of studies seen in green on women with MS and pregnancy, which is mainly, as you can see, concentrated in high-income countries and areas where the prevalence of MS is higher. Next slide, please. So just to share an anecdote on misconceptions of reproduction in MS, I once had a woman with MS who didn't want to see a physician, as she was told it would be unsafe to have babies due to MS. Being a newly married lady, having a baby was her priority, so this caused fear to seek medical attention or iatrophobia. Next slide, please. So similarly, some of you may have seen this YouTube video of Sharifah, a woman from Malaysia, who is on regular DMTs and has had 3 children now. In her early years, after diagnosis, she was told she had a critical autoimmune disease and that medication would affect her reproduction. So she was going to get married and avoided seeking medical attention for her MS for years. Next slide, please. So really anecdotal lived experiences suggest that women with MS in Malaysia want to have families and have many questions. Provision of updated information on reproduction, DMT use and its safety, as well as information on breastfeeding is a priority for them. And these are some really nice pictures of just patients of ours who have got MS and have had healthy babies. Next slide, please. So in my practice, women with MS want reassurance. They want reassurance whether they can get pregnant and information about pregnancy outcomes. So many patients at our center have had good outcomes, and pregnancy doesn't affect the long-term course of their MS. And studies from our country have shown that familial MS is rather rare here in Malaysia, less than 5%. Now, these reassuring outcomes are similar to currently published data that also suggests it is safe for MS women to get pregnant, and the outcomes in most are quite good. Some recent studies published over the last couple of years have also not found an association in most women with MS and an increased risk of miscarriages, stillbirths, birth abnormalities, or ectopic pregnancy. There's been some recent new data from German cohorts published this year that may show newer data. Next slide, please. So fertility is another clinic conversation that often comes up, and this has been discussed by Riley as well. We usually reassure our patients that the majority of women with MS get pregnant successfully. We do discuss that MS occasionally may have an indirect effect on fertility. For example, sometimes it's a personal choice that some women may have with MS may have, that they don't want to have children after discussing with their spouse or their partners. The symptomatology of MS too, such as fatigue and sexual dysfunction, make it sometimes difficult to conceive, and of course, the occasional effect of medications and fertility. But really, what is good to remember is that this also happens in the non-MS populations too. Next slide, please. So conversations also revolve around whether pregnancy will make the MS worse or the symptoms worse, or doctor, will I relapse during pregnancy? Again, there is good data from many groups globally, as well as regional studies. For example, this study from China by Lai et al., suggesting relapse rates drop during pregnancy and that pregnancy doesn't worsen MS. As we can see in this chart on the left, relapses decrease during pregnancy with a rebound effect during postpartum month 3 and 4. And really, that's when we need to monitor our patients a little bit more closely. Next slide, please. Another question that crops up is the use of DMTs in pregnancy. Many, such as Mrs. S that you see here, who was on azathioprine initially due to access issues, and then subsequently on an anti-CD20, with careful pre-pregnancy planning, stoppage of DMT prior to conception, and resumption post-delivery, have successfully delivered a baby girl without a rebound relapse or poor outcome. Recent studies too have shown that even with inadvertent exposures to some MS drugs, the outcomes have been similar to the general population with regard to major congenital anomalies. In fact, some DMTs like interferon, glatiramer, and fumarates may be taken up to conception. With other DMTs, the product insert suggests pregnancy planning and stopping prior to conception. Next slide, please. So many patients with MS in our experience also express fears with regard to their ability to deliver children, the use of epidural and spinal anesthesia, as well as their ability to breastfeed and when to resume DMTs. Now, usually we would co-manage these cases with our fetal maternal obstetricians. In fact, our MS management guideline published in 2015 that you can see on the top right did provide some guidance on this. For many women with MS at our center, they are able to deliver normally, but some with more disability may need some assistance, especially during the delivery when the baby comes out. We also reassure them about the safety of epidural and spinal anesthesia in women with MS and provide letters to their obstetricians about this. Post-delivery, many are also concerned whether they'll be able to breastfeed. Here again, reassurance is needed, and we encourage them not to be stressed about this. And if there are difficulties for the baby to latch, to express the breast milk. With regard to DMTs, we share with them the current data about the safety of interferons, glatiramer, and anti-CD20s and breastfeeding. Some of the other DMTs may not be recommended during breastfeeding at the current time. Next slide, please. So to conclude, it is important that we care for women with MS through counseling, improved awareness, research, and education regionally, not forgetting to empathize with their needs for data and reassurance. With that, I'd like to thank you for your kind attention and happy World MS Day. Over to you, Claudia. Thank you for the slides.
Thank you so much, Shanthi. Thank you for the wonderful presentation. I'm really happy that I actually have to move the slides so I can see them really well, a big screen. So thank you so much. It's really amazing. So hearing from you, Shanthi and Riley, that are both professionals that have so many direct experience in the field. So next, I'm also really happy to present our next speakers that will share their insights as MS patient advocates. So the first is Jennifer McDonell. Jennifer is the Director of MS Information and Resources at MS Canada. She has over 2 decades of experience in MS with a focus on access to treatment and care. She leads the lived experience report related to MS medication to inform government decision on drug access and reimbursement in Canada. And her work is done globally, having served twice as a WHO Essential Medicine List panel member. I think you are already sharing your slide. That's great. So, and then I like to present Gabi Mamone. Gabi, with 1B, is an award-winning keynote speaker, communication expert, and storytelling strategist who helps individuals and organizations communicate with confidence, lead with kindness, and create lasting impact. She's a recognized advocate for DAIB and an ambassador for MS Canada. She's also a proud mom of 2 who believes that kindness is the key to creating real lasting impact. And I'm happy to hand over to you the floor. Okay?
Thank you so much, and thank you everyone for joining today. I'm really happy to be here on World MS Day to provide a brief overview of the lived experience from the perspective of MS organization and how we can support women and their healthcare professionals as it relates to reproductive health.
Sorry, Jennifer, I cannot see your
Yep.
slide.
Oh, you can't?
Everyone else can? So maybe the problem is mine. No, I can see it's like loading. It's a white.
Oh,
I also cannot, yeah.
No one can see them?
I think
No.
also Elisa cannot, so I believe it's a shared issue.
Okay, let me stop sharing. Gee, we're having some technical problems today.
Yeah, it's a little bit weird, but we can make it.
So
Can you try again, please?
Yeah, I'm sharing them the same way I did when we first joined. So,
Okay, now I can see
I can
them.
see them.
they're good now?
Yeah.
Okay, so I will
Thank
just
you.
move forward to the next one. What is very slow, isn't it? MS organizations are often the first place that people come after they've been diagnosed. So as we talk about women living with MS, how can we empower and support them in making informed healthcare decisions? Women living with MS need the most current evidence-based information to ensure their healthcare decisions are made with confidence. And as MS organizations, we can play an important role with education, support, advocacy, and research, allowing women to effectively navigate their reproductive health journeys. The most frequently asked questions, and we did just hear from the previous presentation, so this will be the same, this will be a common thread, but these are the most commonly received questions here in Canada, but they are clearly asked around the world. So information about pregnancy for newly diagnosed, MS medication safety during conception, pregnancy, and breastfeeding, risk of postpartum relapse, pregnancy and motherhood in women living with disabilities, and concerns about passing MS on to their children. In the 20 plus years that I've been here with MS Canada, the type of questions we've heard haven't changed, but what has changed are the answers that we've been able to provide. And this is thanks to advancements in research into our understanding of MS and its treatment and care. We also hear from many women that they don't know where to find reliable and current information about MS and reproductive health. There's so much information available to us now, especially from online sources, but how do we know if the information is accurate or not? While we often rely on healthcare providers for medical advice, not all providers are familiar with MS, which can leave women feeling uncertain and worried about their decision making. MS organizations can support women and their healthcare providers to assess information, as well as provide them with accessible, credible, and current resources about reproductive health. We can develop education programs. We can share pregnancy registry information to help track experiences and outcomes. And we can continue to advocate for access to MS treatments, as well as income and disability support programs. We can create peer support programs for women to connect with one another. And above all, we must listen to our community to learn from their lived experiences. As research continues to advance our understanding of MS, the information we share needs to evolve with it, making sure that women can advocate for themselves and actively participate in shared decision-making with their healthcare providers. To influence positive change, we can work with MS healthcare teams and researchers to share current evidence-based recommendations and develop educational resources that help inform healthcare providers who may not be familiar with MS treatment and care. As we develop resources, we must also engage with our community for feedback to ensure that we're meeting the needs. Because healthcare providers play such a key role in helping women with MS navigate family planning decisions, we need to encourage shared decision-making to create opportunities for women to ask questions with confidence, voice their concerns, and weigh the risks and benefits with their providers. To support these conversations, we can develop resources that prepare women for healthcare discussions because each woman's MS journey is unique. Through lived experience, we can raise awareness, build MS community connections, and ensure we're meeting women where they are within their lives. This is why our project is so important, so we can identify information gaps and create helpful tools for women and their healthcare providers. Together, we can create meaningful change and support women in feeling informed, supported, and empowered along their MS and reproductive journeys. Thank you for your time today, and I'm very pleased to pass you over to fellow Canadian and MS Canada Ambassador, Gabby.
Thank you very much, Jen, and happy World MS Day to everyone. We do want to celebrate, we do, because MS will enhance our lives if we really take that mental approach, that positive mental approach. I remember sitting in my neurologist's office, and she held her hands and held mine tightly, and they were cold. They were so cold, and she took a deep breath. She said, "Gabby, you have multiple sclerosis." And I was newly engaged, thinking I was just about ready to buy a house. I was just going to get married. We were going to start our family. And I actually didn't even know what MS was. I had been going through symptoms for a few years prior to that. I had incontinence. I lost peripheral vision in my left eye. I had tingling fingers and hands, some pain. So she proceeded to tell me that it's a neurological disease of the central nervous system. It includes the brain and the spinal cord and optic nerves, and the brain signals will impact the body, will interfere. And you can imagine that was heavy for me. I was crying in that office. And I remember thinking how scared I was when she said I had several lesions in my brain. Several were close to my cerebellum, which would impact cognitive function and mobility function. And she said, you know, within 10 years, you may want to plan what house you'll live in, what kind of job you'll have. And so all of a sudden, my mind went to, can I have kids? Is my husband still going to follow through and marry me? What kind of life am I going to live? What kind of work should I have? Do I need to live in a space where there's no stairs in case I'm in a wheelchair? Like I was going through all of this pain. I will share with you that part of my saving grace was MS Canada, because MS Canada had chapters and programs that I could be involved with and meet people like me. And I started to get involved with attending the events. I even started to MC some of the events, planning the events. I was on the grants committee. And so I started to be aligned with understanding more about the disease. My husband did decide to marry me, and we did have our first child. And we had our son a few years after we were married. So I had my son in 2008. And my son was born with some medical challenges himself. And so what happened there was I was constantly going to sick kids, constantly going to see the psychiatrist, psychologist, speech pathologist. I had a lack of sleep. He was sleeping with me for various reasons. And so I was tired. I was already lethargic from MS, plus the side of having a baby with some special needs. My symptoms increased, and I felt like I was progressing in my disability. The doctors had shared with us that they recommended that we have a second child to be able to help my son speak, as that was one of the challenges that he was going through. And my husband and I definitely tried to have a second child. We had 3 miscarriages, 4 pregnancies, because one of them was twins. So here I was, 41 years old, wanting a second child with MS, with a lot of symptoms. And I thought, is it too late? Can I still have another child? Can I put my body through this? What would happen if I progress? I mean, I was going into perimenopause, and here I wanted a second child. And I know women are having kids later these days. Shout out to the women on this team if you're one of them. But we thought, let's just try one last time, and we went to see a fertility specialist. And I'm happy to say that's when I call her my rainbow daughter was born, because at the age of 41, we did have our second child, a little girl. I remember being in the mindset with MS that it would change my life. But what I needed to learn was that it would change my life for the better. There are 2 paths that we can take with MS. I could have jumped on that pity bandwagon and said, why me? Why is this happening? I could have really felt sorry for myself. But along with the help of my family, my friends, my work, MS Canada, supporters, donors, sponsors, the fundraising events, all the things involved, I was able to take the attitude of, why not me? And use my voice for change. And so I still have MS. I still have issues. I still have symptoms. However, what I do now is I use my voice to help others. And so MS allowed me to become a public speaker. And I'm a speech coach, and I'm an MC, and I help newly diagnosed people, and I understand because I live the life. I'm very grateful for the therapies, the modalities, the programs, the researchers, all the moving parts that help us navigate through motherhood for women living with MS. It is considered an invisible disability. I still have many, many symptoms, but I know that I'm one of 90,000 Canadians that live with MS. You know, there on average, there's an average, I believe, of 12 Canadians diagnosed with MS every day. And that means every 2 hours. And so we, you, us, what we do is so essential to be able to connect our feelings and what we're going through to be able to live a quote unquote normal life. And I want to thank everyone. I want to thank everyone for your commitment, your research, your time, your efforts, your love, your kindness, all the things. Because what I was able to do with my voice as a result of having MS was I thought, well, I might as well apply to be on TEDx, because that's one of the biggest stages to share a message. And I volunteered. I sat in the audience and I thought, okay, I'm ready to apply. And I was happy to say that my first application, I did. I was on a TEDx stage, and the message was diagnosed with MS, changed by kindness. And if you want to see my TED Talk after this talk, I'll give you a QR code that you can scan and it'll take you to my talk. But, you know, I thank you all for this platform, for what you do to help not just Canadians, but for people globally, because what you do is essential to connect us all for the better. So thank you. Yes. I'm happy to answer any questions before I share that QR code with you. I can even drop my social media handles as well if you prefer to speak with me privately. That's no problem. Claudia, are you able to share that slide by chance?
Yes.
Oh, that's wonderful. Thank you. I found that my computer was finicky when I was logging on.
Yesterday was the day of technical issue for everyone, so don't sweat
Thank
too
you.
much
And I
about
had
it.
to reboot. So when you reboot, then you lose everything. So if you're faster than I am, then that would be great. Otherwise, I can grab it as well.
No, I think I'm sharing it.
Oh, that's nice. Thank you so much. So this is a QR code. If you scan it, honestly, you know, I'm a speaker, and so this is what I do for a living now. So there will be some questions about my talk today. If you choose to add to them, great. If not, it's okay. But when you complete it, it'll bring you to a link with my TED Talk, and then also, like I said, I'll just share my social media handles because I understand sometimes people prefer to have confidential conversations. So you're more than welcome to send me a DM about my journey. I am an ambassador with MS Canada, and I do participate in many of their fundraising events. And I'm just dropping my handles for you. But I hang out the most on Instagram and LinkedIn, if that helps anyone.
Thank you so much for sharing, Gabby. I invite
Thank
you
you.
all to do this. Maybe I think you have another one. Okay, this one.
Oh, that's just my handles, but I did drop them in the chat box if that's
Okay.
easier. So thank you so very much for that, Claudia, and everyone. I appreciate this opportunity. And by the way, if you want to hear something fun, when I sat in that neurologist's office and she said, you know, within 10 years, you may progress. I want you to know that it's been 21 years since I've been diagnosed, and I can remember my speeches, and I have mobility, and I am positive, and I'm a great mom. And so with the right support, we really can achieve so many things.
Oh, thank you so much, Gabby. Wow. And also thank you to Jennifer. Like, I think we collectively don't talk enough about the importance of patient association and the community that comes with them, really. So, like, thank you so much for this. I really invite everyone to check out the links that Gabby shared and provide her with a feedback. And I think like we have already some question like in the chat, but invite also you all to please use this conversation to write anything you have in mind, curiosity, any question for Gabby, Jennifer, Shanthi, Riley, and for Elisa that I'm going to present right now. Elisa will share with us a research perspective. So Dr. Elisa Baldini is a neurologist and epidemiologist working at the Unit of Epidemiology and Statistics at the IRCS Institute of Neurological Science of Bologna in Italy. She's a member of the GRADE working group on and the scientific panel on neuroepidemiology of the European Academy of Neurology. She's also a board member of the Italian Association of Neuroepidemiology. Within Cochrane, she served as an editor for the Cochrane Review Group MS and Rare Diseases of the CNS, as well for the geographic group Cochrane Italy. She's a close colleague of mine, so we're really happy to give you the floor, Elisa.
Thank you, Claudia, and thank you everybody for being here today. And I wanted to thank the speakers before me, everybody. That was very interesting for me listening to all of you. And I want to thank Gabby for the inspiring and emotional talk that you just gave. So thanks. I'm going to share my screen. Oh, I'm sorry. That is different from before.
Let's wait.
Well, yeah.
Finger
Sorry,
crossed.
it's just, yeah, no, it's just different from what we did before. So maybe that was the, okay.
Okay, we can see it.
You see the presentation mode?
Yes, great.
No, thanks. Okay. So as Claudia said, I'm going to present a research point of view. So it's a project actually that, and the idea started spontaneously among some people, some of the people that are also here today, that are interested in research and care of people with multiple sclerosis. And that was following a previous collaboration on, and that was actually on the application for the inclusion of multiple sclerosis disease modifying drugs to be included in the WHO essential medicine list. And note that it was successful, so we were actually able to get that approval and the inclusion of three drugs in that list. So the project that I'm going to talk about today is called Knowledge Gaps in Reproductive Health Management for Women with Multiple Sclerosis and Healthcare Professionals. And it's, it sum up a little bit of the aspect, the points and issues that came up during the different conversation today from the clinical point of view and also at the advocacy point of view. So what we wanted to do was to try and go a little deeper into define what are actually the knowledge gaps, all the knowledge gaps in reproductive health. So the project has a multi-interest holder advisory group now that is working both on the organization and the scientific aspect. From Cochrane MS, there's Francesco Nonino and myself as methodologists. We're both, actually also Claudia as a research fellow, we are all from Cochrane MS. And then there are some neurologists interested and that are working with people with MS, and they are working also on the research part, the research aspect of multiple sclerosis, and as Riley Bove that just spoke, and Shanthi, but also Dina Jacobs and Diana Saylor. They're all actively working on all these issues. But the group also includes representatives from advocacy groups, as Jennifer, that is here with us, and from MS Canada, and Nick Reichen from MSIF. So the aims of this project are to address knowledge gaps in reproductive health among women with multiple sclerosis, but also address those knowledge gaps, information needs, and concerns raised by women with multiple sclerosis from the perspective also of the healthcare professionals. And the final project that I wanted to achieve is to develop a core knowledge set on reproductive health for women with multiple sclerosis to be disseminated globally. And something that I wanted to highlight is that this project is, however, it doesn't have any funding. So it's all on voluntary basis. And it's an important aspect for us also. This project has a mixed method approach. That means that we are using different methodology, different path to get to the final outcome. So we're doing a literature review to get the information from the literature, the published literature, and then we developed 2 international online anonymous surveys, one targeting women with multiple sclerosis and one targeting healthcare professionals. And these steps all are directed to develop this core knowledge set in order to have it defined in a plain language, enriched with illustration, and to be disseminated again globally. So here is it's a graphical representation of the whole project. The starting point is the question that we ask ourselves from the beginning. What are the global knowledge gaps on reproductive health in women with multiple sclerosis? And in order to answer this question, we worked into 2 steps. And so we started first with a literature scoping review in order to evaluate what was already published on this topic. So on the topic of knowledge gaps in reproductive health in women with multiple sclerosis. So specific questions about that. And the findings from the literature informed the creation, the development of 2 online anonymous surveys, which were actually created with the input and the help of the scientific advisory group that I showed you before, in order to have to collect the information that we actually needed. So the two surveys, as I said, of the 2 surveys, one is directed to women with multiple sclerosis, and this is translated in multiple languages in order for all women to have access and to be able to answer that without without the need of having it translated by someone else, while the survey for healthcare professionals that are actively involved in the care of multiple sclerosis, it's only in English. In both cases, the diffusion and the promotion of the survey or the participation to the project is going to be facilitated by country champions that are distributed in different areas, and I'm going to show you that in a little while. And these people are part of the project now. All the data that are anonymous are going to be collected centrally and analyzed centrally by us, and that with the oversight of the whole scientific advisory group, it will help. It will determine the development of what we wanted to obtain, that is the core knowledge set for women with multiple sclerosis, to be able then to disseminate that. And if you have questions on this, of how the project works, we'll give you the opportunity to ask for more information. So far, there are 15 countries currently participating from the Global South, and we're very happy and excited about the responses and the participation, the enthusiasm that we felt from the country champions that are now they are now ready to work with us. There is also and representation of countries from different income levels, and so more than half of the country participants are participating are lower middle income level. So this is also important to have a representation of the different characteristics on this aspect. So an important news and important date now is that start of the surveys. I'm going to say that today, for the first time, we can say that both surveys for the one for women with multiple sclerosis and the one for healthcare professional is going to be open. They are both going to be open online for 6 months, starting from June 5th, so next week. And so the project can actually start now. And so thank you, everybody, again. And these are our contacts for Cochrane MS, and the link also to, and the link for, you will find also the link for our website. And for those that will want to participate as to fill out the survey for women with multiple sclerosis and healthcare professionals that are directly involved with multiple sclerosis, you will find the link on our website from next week when we will open the survey. And then, well, if anyone else wants to talk about possibly becoming another country champions, we will be happy to chat about that. And you can email us and or say something on the chat, and we will be in contact with you. Thank you.
Thank you so much, Elisa. I think global projects like this one are so challenging, but so rewarding in the end. We have so many, they bring together a lot of people with different background and expertise in any stage of the project. So it's challenging, but I think the outcome is going to be great. So thank you so much for your presentation. And we will start right now the last but not least part of this event. So I'll now give you all access to the microphone. And I just ask you please to keep it mute until you are speaking. So if you want to ask a question, you can raise your hand and talk right now. You have access to it. You can also open your camera so we can see your face and trying to have a sort of, virtual conversation that is more likely resemble the reality. I will start right now reading the Q&A question because we have just one, but I think it's, I can twist it because Michaela is asking us if we can share the PowerPoint about the presentation. And of course, Michaela, we are going to share the PowerPoints. But also she said that she wants to show that to her obstetrician. So I actually want to use this opportunity to ask mostly the clinician, but also Gabby and Jennifer, how would you address this? For example, you are the healthcare professional, or you are the person with MS, and you have to show something like the slide that Riley or Shanthi present to the professional. How would you react? Do you have any insight about that? What's the best way to address this? I'm a patient, I know this about my health, I want you to know that,
I can weigh on this one. I think this is your life, this is your family, this is your health, and there are data that support what you want to do. And so your health and your family, and apologies, I'm at a conference, apologies for the background noise. Your health and your family, are the priority. And so I think if you go into it with a recognition that no doctor is up to date on everything, and it could be helpful for them to have you point to information or evidence that might change their mind about something. I certainly appreciate it when patients tell me about new developments in the field that I may not be aware of. There's no way I can know everything. So I think if you approach it as a partnership, as a shared decision making, and asking that your doctor use the best evidence to guide you, I think that can be very productive, constructive way of having the conversation. But my experience, I had a patient the other day who came in. She was postpartum. Her physician would not restart her infusion therapy until she stopped breastfeeding. And even though that's not a recommendation anymore. And so she came to me to see if I would start her medication. I said, I will, but tell your doctor I'd like to speak to him. And within half a day, he didn't speak to me. He just probably looked up, the name, the data, the stuff, got up to speed, and he prescribed her medication himself because he was her doctor, and he really should have just done 2 minutes of research. So I think if you just approach it with the idea that people are just busy and they have had a big gap when it comes to women's health, and you can help bridge that gap with a nice paper or two, I think that can be a constructive way to go forward.
Thank you, Riley. I don't know if other reviews panelists want to share more insight of these,
I can, from just an MS organization, that we would absolutely, as Riley said, share the data. We would try to, get the paper, the actual article, or several for the individual so they could share that with their physician. Not just sometimes, presentation is great, the references are there, but if we can actually get that paper and reduce the amount of work, then we will do that. Yeah.
So maybe I can add to that. I always tell my patients that the data is always evolving, and it's a shared decision between you and myself. And at the end of the day, MS should not prevent you from doing what you want to do. Yeah. So that's one of my takes on this.
Thank you so much. It's so nice seeing this switching power. As a patient myself, for other stuff, I found it so incredible, the idea of going to my doctor and telling them, okay, this about this, can we, share this decision? And I think it's actually revolutionary, beyond MS. Yes, Gabby, please.
Thank you. I can chime in from a patient perspective, and that is, it's important as patients that we respect the medical profession and we respect the doctors, the neurologists that have the knowledge. It is important that we are our own voices. So I am very happy to go with papers and reports and books and share my thoughts, but I come from a place of love and wanting to understand if it's the best solution for me, but ultimately I need to trust that they are in the rules for the reason, and the trust is there. They know my medical history well, but it is up to me to provide them with the data. And, for any patients on the call, what's been helpful for me in my MS journey is I have an MS notebook. And anytime I have a relapse or anytime I have an issue, I write the details on my journal and what I was doing right before then, because then you'll actually start tracking metrics of, wow, I was really stressed about this, and how ironic that I had an MS attack right after, so it's a really nice way to be able to go into your doctor's office with data. And I think they appreciate that. Mine does anyway. I have a great medical team.
Thank you, Gabby, for sharing. So I'm seeing in the chat there is some question about specific drug and pregnancy. I don't know if we are able to go over there, but I can try since I'm not seeing a lot of other question. For example, Chalmari is asking about Mavenclad and pregnancy and about its recommendation. And I see that Michaela is asking about ocrelizumab and trying to get pregnant. I really like these are sort of questions that clinician and doctor may answer better. And of course, we have to look over the individual case. So I don't know if Riley and Shanthi may want to say something about that, or we have other questions.
Yeah, maybe I'll just, Riley, you go ahead.
For the ocrelizumab question, we're really just recommending 0 to 3 months and just making sure that people are not pregnant at the time of the infusion. So there is going to be heterogeneity there in clinician comfort for that, because the data that we have for ocrelizumab, the Minori study, are presentations. So I just presented those data yesterday. We presented them at AAA and ECTRIMS this year, but they're not published yet. So there may be a little gap between our new EMA guidelines, which is 4 months, and what we're recommending as physicians, which is 0 to 3 months. And that sometimes is a hard gap to fill. The good news about ocrelizumab is if you've been on it for at least 2 years, people are very, very stable if they're not going more than 6 months between treatments. So you do have a nice window to try to conceive.
Yes, I saw in the chat about cladribine. Based on the label, I think they still recommend that you should use conception up to 6 months after the last dose. So it's still not advocated that you get pregnant within that 4 to 6 month period. I mean, sometimes we use 4 months from the last dose, but still advocated that you don't get pregnant during that period. Just coming to rituximab on a case-by-case basis, when we've had very aggressive MS patients, we have had some patients who have taken rituximab during the pregnancy, but we monitor very carefully the babies who are born to see that they don't have any depletion in their B cells. So on a case-by-case basis, we have had some pregnancies with rituximab. I don't know what Riley thinks about that. And I agree with the ocrelizumab presentation by Riley.
Thank you so much, Shanthi Riley. So I think we have another question about the relation between period and MS. So it's like, as Riley shared in the chat, like doctors may not have adequate training in women's health. So there is a gap to fill, and we cannot agree more. So yeah, thank you. Please.
It's a great question, and we hear it all the time. And when we've tried to study it, just a few groups have tried to study it, others just haven't at all. But when you try to study it, it's actually very, very hard to study methodologically because everybody's menstrual cycle is actually quite different and everybody's symptoms are quite different. And so to see an effect is quite hard scientifically, even though we absolutely know it and believe it from a patient perspective. Maybe it's fluid shifts, maybe it's immune cell shifts, maybe it's, many different things. So I think these are really important experiences. And one thing we've tried to do for people who really have a lot of fluctuations in their symptoms around their pregnancy is put people on the continuous oral contraceptives. So 3 months of medication, 1 week of placebo for the contraceptives. And that means that you only get 4 periods a year as opposed to 12, which can help a little bit for people who have a lot of fluctuations. But for people who don't want to be on that, I think just anticipating that it's going to shift for you and maybe taking a medication for fatigue or, giving yourself a lighter day or something like that can be useful as well, because it truly happens and we truly don't know what to do about it. Yeah.
Thank you, Riley, for this insight. So there are, okay, Gabby's making a question. You can also open your mic, Gabby, if you want, or I can read it out for you.
Sure. I was curious to know, is there any risk with a parent who has MS and passing it to our children? Is there anything that we as parents can do to mitigate that if it is a concern?
So I can take that one. I think as a parent, or if anyone else wants to step in, for sure. I'm sorry if there's a delay.
I think Shanthi was ready to
go for it, Shanthi. Sorry about that. There's just a delay on my end. Sorry.
No worries. I mean, our neck of the woods, familial MS is very rare, and it's not inherited in the common manner. Like if your father or mother has it, it's not a definite thing that the children would get it all. So it's not inherited in the typical manner. So those who have twins, they're slightly higher risk of inheriting it, but it's not inherited in the commonest manner. In our neck of the woods, it's less than 5%. So the risk is very, very low.
That's comforting to hear. Thank you. I always think when my son complains about pain in my mind, I'm like, is that related? You know, like you just have this uncertainty. And so I appreciate that, that statement that it's rare. Thank you.
Thank you, Shanthi. Thank you, Gabby, for the question. There are like any question here. Do you want to raise your hand or open the mic? I think we have time for one or two more since we started a little bit late. Or even if you want to share your experience as a researcher, patient, clinician. I don't know, everyone has their own experience in this, of course. Okay, I think I can make one that actually I was curious about. So we talk a lot about the gaps that women with MS had, of course, and as Riley mentioned, there are gaps in doctors also. They're not trained in reproductive health. But I like asking a question mostly to the experience of, the panelists there is, what kind of gaps do you see in your experience in the healthcare system that actually could support, provide information to women, like when women with MS go to the doctor, not just in the women and the doctor, usually there is a system behind, a system of made also by patient association and the nurses and all the multidisciplinary team behind, if there is. So I was asking, I was wondering if you have any insight about the healthcare system gap that could be improved, or maybe they're just great enough to inform the women.
I can provide a little bit. Well, I just think that the way that the healthcare system is now, and I don't think it's exclusive to North America, is it's a bit challenging to get primary care. So just ensuring that when we are looking at information for healthcare professionals, that we're doing it in a bit more of a broad stroke, including pharmacists as well, because I think that the pharmacist plays quite a big role in the care of individuals. And then something that's come up in Canada, and I don't know if it's come up in other countries, but we do have, midwives and doulas who are not, who have put women living with MS on a high-risk pregnancy, and they won't take them on as patients. So this is an area for us that we'd like to, we hope that this project will also help inform that group of reproductive health professionals.
Thank you, Jennifer. Yes, Riley is emphasizing in the chat that a collaborative care model is critical if that means coupling care together with phone calls so that women do not receive mixed messages. And that's really, really true. The problem of overload information, as Jennifer mentioned in her presentation. Okay. I think we don't have a lot of other questions. Okay. So I send you all the, thank you so much for joining us today. Really was amazing, hearing all your experience and your insight about the topic. So please, I don't know what to say, I'm sorry. So please, thank you so much for joining us today. And you can see all our contact also in the chat. our email and our website, where you will find the survey, both for women and for MS healthcare professional, as well our Instagram and LinkedIn page if you want to follow us for updates and all over our activities. So thank you so much, really, and thank you for all the speakers and all the participants. So thank you. Goodbye. Have a nice day, a nice evening, or even good night for someone, I guess. Thank you so much.
Thank you.
Thank you so much.
Thank you.
Thank you very
Bye.
much.
Thank you.
Bye.
Thank you.
Thank you.